Good morning. Bonjour. Social science in the house. Bonjour et bienvenue à la séance plénière sur les sciences sociales. C'est formidable de voir les sciences sociales représentées ici au CAHR. Welcome to our social science plenary. I just want to very briefly say that what is amazing seeing so many of the faces here, colleagues, friends, people who've been doing such incredible social science work for short periods of time and for long periods of time, who have done so much incredible work that it's just really an honor to gather and to be thinking about the impact of our work in relationship to the epidemic. Social sciences have been a critical component of our work. So thank you for being here this morning. I think what I'm going to do is just turn it right over to my fabulous colleague who will introduce our amazing speaker this morning. So thank you, Kathy.
Thanks, David. For those of you who don't know him, and I can't imagine there are many, but this is David Brennan from the University of Toronto.
Oh, I should introduce myself, sorry.
There we go, I just did, yeah, tag team. So I'm Kathy Worthington from the University of Victoria. And as we get started, I'd like to acknowledge that we're on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. In addition to acknowledging that we are on First Peoples lands, this statement is always a reminder to me that as an HIV research community, it's our responsibility to work with First Nation, Métis, and Inuit communities across the country to support them to improve their health and well-being. It's now my great pleasure to introduce our 2018 Social Science Plenary Speaker. Bernie Pauly is an associate professor in the School of Nursing at the University of Victoria. She's a community-engaged scholar, and although she'd be the first to say that the work is not about her, you can see from the program description that she has many appointments and awards that speak to her research accomplishments. Her research focuses on reorienting health and social services to reduce health inequity and prevent harms of substance use. When David and I were discussing what topic or issue should be profiled in the social science plenary track this year, we felt it important to bring to CAHR the issue, the drug supply poisoning, that is having such a devastating impact on our communities and on AIDS service organizations, both here in BC and across the country. Bernie brings us a perspective that integrates our HIV work into its broader social and structural context. The title of her talk is So What Now? Working Together to Address Structural Inequities and Harms of HIV and Overdose. And thank you in advance, Bernie, for your talk.
Good morning. The photo that you see there is Cadborough Bay. Cadborough Bay sits below the University of Victoria, which is on the traditional territory of the Lekwungen-speaking people. And I acknowledge with respect the Wasanic, Esquimalt, and Songhees people whose traditional relationship continues with the land today. I also want to acknowledge all of those that we have loved and lost to the HIV and overdose epidemics. I have conflicts of interest to disclose in terms of much of this research has been supported by various research institutes, Canadian Institute of Health Research, the Michael Smith Foundation, and the Vancouver Foundation. So I want to do three things. I want to talk about the very important role that the HIV movement has contributed to mobilizing harm reduction and how we need to and will continue to reframe harm reduction during an overdose epidemic. And how beyond that we need to shift from a biomedical, neoliberal, individualized focus to more health equity focus and create a health equity movement to address the underlying root causes of public health emergencies. And then reflecting on ourselves, I'm going to particularly reflect on the role of research and researchers, and if there are lessons for clinicians and policymakers, I hope we'll have a chance to engage around that. The HIV movement has been extremely powerful in bringing to the fore the importance of harm reduction, and particularly safer supplies and safer spaces, and looking for cures. The fight for safer spaces is symbolized by insight, and that was really my introduction into the movement of harm reduction. And recognizing that as a nurse, I was positioned to draw upon things like my code of ethics, because my code of ethics say things that I should treat all people with dignity and respect, and that I should use the best evidence available in my practice. And so able to mobilize the profession of nursing across the country to say that is the basis on which we support evidence-based interventions like supervised consumption sites. However, in spite of that evidence, in spite of those values, we have had extreme difficulties in terms of implementing harm reduction fully over the years, over the past decade. This is a paper that comes out of a Canadian project led by Cam Wild and Lane Heischka at U of A, and it has been looking at harm reduction policy across Canada. And I just want to read for you a statement. This is one of several papers that our team has been putting out. While harm reduction implementation should be routine given the evidence-based considerations are often less influential than political issues. And if you think about it, it often takes a decade or more to implement a supervised consumption site. And if you look back in history, it took a decade or more to establish needle exchange services. So evidence-based interventions are not being fully implemented or often limited in their implementation due to politics and economics. And so we have to grapple with the social, political, and economic conditions in society in order to fully integrate and scale up harm reduction. And the lack of scale up, I think the phrase we heard most often that reflected that discourse was, insight being referred to as until recently. I changed it. It used to say North America's only supervised consumption site, but now we can say until recently. So with the advent of the HIV epidemic and the scale up of harm reduction, if we unpack that a little bit, what we see is the dominance of the biomedical approach, and that harm reduction often got implemented, and I know this wasn't intended, but it often got implemented as providing clean supplies. And that was the primary way in order to disrupt HIV or hepatitis C infection, and it didn't often get paired with the philosophy and the broader understanding of harm reduction. It also, and many of you will have read critiques about it being taken up as a neoliberal individualized discourse in which the responsibility goes upon the person who's using substances to change their behavior without addressing broader structural conditions. So there's two kind of problems that emerge when harm reduction, and particularly in this case, safer supplies get implemented that way, and they're different, and I think these two problems highlight the complexity of trying to implement harm reduction. And it's interesting being a community engaged researcher because we're kind of always in the community working with our partners, and we've got this whole, my colleagues Bruce Wallace and I have this whole series of studies that we've done over close to a decade now, where we were actually seeing how harm reduction was unfolding, and I'm going to draw from that now. So in terms of implementation of harm reduction, this is an example where in a setting there are safe supplies available, but the way that harm reduction gets practiced in the absence of a philosophy of harm reduction, in the absence of policies of harm reduction, is it's practices in these ways in which people turn away, or as this person said, so sometimes we just turn a blind eye on it, and they're referring to substance use. You know that you're doing it, but you know you have to keep them safe, right? And so we have people using alone in their rooms in this kind of scenarios. Staff also talked about the mixed message that's given when you give supplies, and then we say, okay, go out in the street and use those. Go out in the unsafe setting of an alley or somewhere else to use those supplies that we've now given you, because we don't have spaces. And that still exists, even though we've had rapid expansion. Here's the other problem that exists, and this comes from a couple of studies that we did in hospitals, where we have a harm reduction philosophy, and you will hear practitioners say, we have a harm reduction philosophy. And if you ask them what that means, they'll talk about the fact that they treat people with respect and dignity. They try to practice in a way that doesn't judge or label people for their drug use. So they've got the philosophy part. But then when you look at the substance use and harm reduction policies, they've generally got zero tolerance policies for substance use, and there's often a lack of harm reduction policy. And in this particular study that I'm referring to here, you see some of the quotes that come out of those policy documents and statements about not being able to use drug and alcohol on site. We see this in our shelter work as well. No, we don't have clean supplies. Alcohol and other drugs are prohibited and will be confiscated. And when we asked nurses in the hospital, we said, you know, they said, yes, we've got a harm reduction policy. And we asked them about that policy, and we simply couldn't find it. They had a philosophy, but not a policy to support their work. And those kinds of things, while they are changing, and I'll talk a bit about how they're changing, they do still continue because we don't have even implementation, and our implementation of harm reduction is quite uneven. For those of you that are in British Columbia, we often, when people talk about the overdose and we're looking at the prevalence, they'll show maps of British Columbia, and over the last about 8 years, how the rates of overdose have rapidly increased, and you see darker and darker areas where the rate of overdose has increased exponentially. But what I always think when I see those maps is, are the harm reduction services being scaled up proportion to the harms that we see? And you know, what we found in our work is that when we have this kind of challenging situation around the implementation of an evidence-based response, is that we have unintended consequences. And this is an example from our work where, in the absence of supervised consumption sites in our community, washrooms were serving as de facto consumption sites or unsafe sites. And that situation has changed. We now have 4 overdose prevention sites in our community, and that's been an important move forward. This was done in 2016, where we looked at police data and other types of data and saw that a lot of overdoses were occurring in washrooms. A fact that anyone who works in the community knows was happening. It was just our way of documenting it. And as I said, now there's been the establishment of overdose prevention sites. So some of what I've shown you is a bit historical in terms of our own community, but it is a reality in many other communities where harm reduction services are still being scaled up or haven't been radically scaled up. So as we have been scaling up harm reduction services, and in terms of the overdose, the introduction of naloxone and the importance of now shelter settings becoming first-line responses. And this is an example from a more current study we've been doing called Sheltering Risks, where before we ever had naloxone, that's what we'd do. We'd call 911. You give them as much information as you can. But now we're being required to train in naloxone, so it's an added burden, an emotional burden. And another one, we're not paramedics, but we're first responders a lot of time. And so I think, you know, the way that first responders were being talked about in the media was around police and fire as the first responders, when in reality it was shelter workers and people who use drugs who are the first responders and continue to be the first responders. A nurse I know observed just the other day how she witnessed shelter providers responding to an overdose and how complex it was and the challenge it has for us as clinicians, and we have people who are extremely skilled in that area. And so the impact of that on our first responders, and this comes again from a staff person, we care, we're supporting that person, we're making goals with that person, we're having day-to-day interaction, and then that person's on the floor almost dying. So think about the fact of the relationship that's there and how this is impacting our frontline responders who are now responsible for administering naloxone. I work a lot with organizations of people who use drugs. I have naloxone in my bag. I'm extremely aware that if I'm in the situation of an overdose, they're probably more prepared to respond than I am, in spite of my nursing kind of training, and how responsible I would feel if it's someone that I know and that I'm working with. So we have to recognize some of these impacts as we're doing our implementation. So without a doubt, we've had a rapid scale up of harm reduction during a public health overdose emergency that has gone far beyond anything that I could have imagined in those early days when we were in the fight for space and we were working to establish supervised consumption services. And this is specific to BC, so in a BC context. In terms of the scale up of naloxone, the access to Suboxone, heroin prescription, the rapid expansion of overdose prevention sites. We now have almost 25 overdose, I think more than 25 across the province that have been established. Slow release morphine. We've got work going on around drug checking, determining what's the best approach. And then I think critically, Bruce, my colleague who I mentioned earlier, is looking at how do we implement that in a way so that we do not have unintended consequences of drug checking. And then, of course, impacting all of us, cannabis legalization. I should say, I can go back, yeah. Just so that you're aware, on the right there, that's an example of one overdose prevention site. And we did actually a rapid impact and evaluation study. And one thing that we noted when we looked at the implementation is overdose prevention sites were scaled up very quickly. From days to weeks they were implemented, and they were implemented without any negative community backlash. And for many people in the community, when we asked them, we said, how do you think this is different than a supervised consumption site? They said, well, we don't really, this was clients and people who were providing services said, well, we don't really think there's any difference. But what we found is that the sites are actually very low barrier sites, and some of the policies that have traditionally been around supervised consumption sites, like jugging, for example, or age restrictions, some of those kinds of things have been radically rethought in the overdose prevention sites. So in harm reduction, from the HIV movement to the overdose epidemic, we've had a really radical shift, I think, in how we think about harm reduction in a very mono-focused way to a much more complex way. And I just wanted to lay out for you, this is just a schematic that I came up to try to illustrate the fact that we need a much more robust understanding of harm reduction. And on your left, starting with safer use, and you think about the focus on clean supplies, safer use education, take home naloxone as an example, but we can also think about things like food and water as basics to safer use. Moving to safer policies and practices, and how do we challenge those policies and practices? And it's amazing to me that we're in the most fulsome conversation right now about drug policy reform. In our own communities across the island, there have been discussions on decriminalization, legalization, talking with the public. Moving to safer spaces, which I've already touched on, in terms of integrating supervised consumption into housing, into shelters, into drop-in agencies. We've been creating safer spaces wherever people are. And, you know, in my own work, I, along with Tim Stockwell, lead the Canadian Managed Alcohol Program study, which is looking at safer drinking spaces. And we have yet to really have that kind of fulsome conversation. And so in terms of safer spaces, thinking about managed alcohol programs and the integration of those alongside of other type of harm reduction interventions. And then to the right, moving to safer sources, in terms of opiate substitution therapy, and a variety of ways to provide us to alter the currently unsafe drug supply. But you'll see on the bottom, what has to underpin that all is social inclusion, dignity, respect, compassion, trust, and user participation in it. And I can't sort of speak to that piece enough, because the way that we do this and mitigate unintended consequences is through engagement with people who have experience, who can bring that experience to the table, because they live in the midst of these situations and know how things will impact themselves and their community. So if we just take, but I think we need to do a little bit more. I know that's a lot, but what I want to move to next is, how do we actually create a health equity movement that brings together the HIV movement, that responds to different types of public health emergencies and epidemics. Many of you in public health will be familiar with what we call the social gradient. I haven't quite got this perfected, so I look for your critical feedback. But if you think about that social gradient where, socioeconomic disparities result in poorer health, using that kind of idea to show on the left there the overdose deaths and harms increasing across the population, because this is not a disease of addiction. It is constantly being framed as a disease of addiction, but it has reach across the population because, of course, people use substances for a wide range of reasons. It can be to mitigate against trauma and pain and coping strategies, but it also can be to relax, for pleasure, for youth in terms of experimentation or exploration, which is a normal developmental phase. So if you think about it, everyone is impacted by an unsafe drug supply on the bottom. Many people were impacted by changes in opioid prescribing. In BC, we've got many documents that highlight the insufficient treatment system that we have, and people being able to access treatment on demand just has not been a reality. There's often been long waiting lists, or services don't exist. And then I think we layer onto that health inequities and what I call the context of harm, things like colonization, the criminalization that is disproportionately impacting some communities over others. So if we're thinking about a health equity movement and a health equity response, we have to consider those contexts of harm, the poverty, homelessness, colonization, gender norms, heteronormativity, current drug policy, age considerations, trauma, and intergenerational trauma. Because a lot of times our response is very biomedical, which I've highlighted in a public health emergency. And you can think about HIV responses, you can think about overdose responses, and how those get framed as diseases, which actually limits our responses in terms of addressing the context of harm. So we have to unmask the root causes of public health epidemics, challenge the neoliberal biomedical discourses that mask the root causes of HIV and overdose. We need to move towards health equity, public health discourses that highlight the structural inequities that produce these epidemics. So I could just stop there, and a lot of, I think, when you engage with critical work, that is a place we often stop. But I'm ultimately very practical. I'm very interested in applied research. And so I always want to give something more to engage with you, to think about, okay, so what do we do with all of that? That's pretty big, that's big stuff. There's a lot of different pieces to it. And one thing we did in terms of the overdose is we created this little public health guide to overdose responses that tried to pull together all of that in a practical way through our Canadian Institute of Substance Use Research. So that's one kind of practical thing. But here's another. And this is a very theoretical kind of slide, but it's kind of what I often have in my head when I'm sort of thinking about this, and I'll try to kind of lay it out a little bit in thinking about, if we're going to create a health equity movement, we need some tools, we need some resources for how we can do that. And so we've got a project called the Equity Lens in Public Health, where we've been trying to describe, well, what is an equity lens? And what we did is we started with a lot of the literature on the right around what some people that comes comes out of critical theory in terms of what people call the isms, those things that embed stigma and discrimination into systems and are often addressed through work with communities who recognize those isms and who can bring them to light. In the equity lens, we also want to think about in not just that intersectionality and how people are positioned, but in complex ways about how that interacts with health systems, other types of systems as well, and how do we actually respond for a health equity response? How do we promote social justice? How do we recognize power and privilege? How do we move towards decolonization and inclusion and fair and adequate representation? Those are kind of some of the big ideas. But when it comes down to the actual actions on the bottom, thinking about things like peer and family inclusion, cultural safety, trauma and violence-informed care, harm reduction philosophy and principles, and being clear about what each of those brings and how do we integrate in our practice. One of the things we're working on is the development of a framework that tries to bring some of these things together. So thinking a little bit, and I'm going to speak from my perspective now as a researcher who's involved in the community, who wants to aim for practical and applied kinds of solutions, thinking about what my position is, and then I hope engage with how you see yourself. How do we see ourselves as advocates, allies, and activists? You know, I can be an advocate, I can sit in the room, I can argue for more harm reduction policy or better harm reduction policy or inclusion of people who use substances. I can do that, that's the advocate. I can also, though, align myself and be with groups of people who are impacted. So I work very closely with Solid, who's Solid Outreach, who's an organization that's run by people who use drugs, for people who use drugs, and try to put myself in the position of ally. I don't do a very good job. I'm not a very good, I don't think, activist, although we can think about how we bring activism into those advocacy and ally roles. This picture you see around disrupting for equity came from some work that we did early on with some of our community partners, where the sort of challenge was that communities weren't engaged in research. And what we said is, actually that's not the problem. We're seeing that our communities are very engaged, they're very interested in research. We don't necessarily have researchers who can engage in the community. And so I think, you know, I'm reflecting from the research side that those capacities, and I think the HIV field and the work that you have done around building the capacity of researchers and the capacity of communities is amazing, and we're all learning and drawing from that, because remember, this is coming from my context of working in a substance use field and working in fields of homelessness where we don't have and are learning from and drawing from the work that you do. So social movements are central to population health advances, and so I think we have to ask ourselves some hard questions. When you know the evidence, can you do anything but be an advocate? Someone asked me during, we had a tent city in Victoria, and someone asked me, you know, kind of why are you so involved? And then someone else said, well, I guess, Bernie, you know the evidence, so you can't do anything but be involved. So we have to keep thinking about what does the evidence say? We have to constantly bringing the evidence to the table. The second point should be a question. But when you do your slides a month in advance, sometimes you don't always pick up these things. But it's really the question about, are we bringing critical consciousness to our work, and how are we taking radical action in our everyday work to start to shift those, whether it's at the individual level, the program level, the policy level. And I think as researchers, we have to really grapple with these questions of advocacy, allyship, and activism, and where we stand, because we want to be able to influence policy. We want to make systems better for people. And then to what extent are we able and willing to challenge the current system? In public health particularly, advocacy is not a reality. It's not easy to do, to be an advocate, and you run risks. And we talk about it in our research as biting the hand that feeds you. And that applies, I'm sure, across other positions as well. So what I want to kind of end with is a little bit about work that we've been doing from a research perspective, where we've been engaging with opportunities in our community to do some of that work, to make some of those kinds of changes. I think many of you, I know you will be very familiar with patient-oriented research and the development of the Spore framework in Canada, the public involvement work in the UK, the guide there to evaluating public participation, and then patient PCORI, which is the US version. And just noting, we use the word patients in Canada. In the UK, they use public involvement, which is a different orientation. And I think there are some real opportunities for us as researchers and communities through these initiatives, and I'm guessing you may have already talked about them, so I'm just going to give you kind of our examples around that. I think, if you think about the alignment with community-based research, the rationale for POUR is that it empowers patients, it's more responsive and responsible research, it optimizes research's designs, enhances validity, improves KTE, and the effectiveness, efficiency, and delivery of healthcare services and programs. So it shifts the power. This is a fundamental shift in power that is in policy that says we are going to, and I put in quotes, go from researcher-driven to patient-driven research, and the questions and the way that the research is done and how it is implemented is informed by people in the system, use the system. So we were funded under the Spore Initiative to do a project which focused on reducing stigma in primary care and building capacity in patient-oriented research. It's led by Karen Urbanowski at the Canadian Institute for Substance Use Research, along with myself. And you see there a picture of the members of our core research team. So in this project, we specifically brought together patient-oriented research with community-based research. And I think community-based research as a platform for bringing together communities with policymakers, because the Spore framework makes very clear this is about enhancing the system, making changes in the system, and having policymakers involved, but driven by patients, clients, communities. So in our research, we had to really think about a lot of these things because we were bringing a lot of different players to the table, and you'll be very familiar with this from the community-based research world and the type of models that you use around peer research. I had done lots of research that used an advisory model where we had peers as advisors. I had done research that employed peers, but this was the first time that we had fully partnered with peers, 2 organizations run by people with past or current experience of substance use. Solid and Umbrella are the names of those 2 organizations. And we really took that partner leader model, but they were also fully engaged in data collection and analysis. So we did something else though. We looked at ourselves and we said, is this Spore framework adequate for all of us working together to guide culturally safe research with people who use substances? That was the question we asked ourselves. So not only did we collect data on what makes people feel, we used the cultural safety as our framework, and we asked the question, what would make you feel safe to go to the doctor? Or I would feel safe to go to the doctor if was our guiding question, and we came up with a range of answers to that. We also looked internally at ourselves to say, how are we doing research in a way that is safe, culturally safe as well? So in order to do that, we had to come up with a way for our research team to work together, because we were so fortunate. We had really excellent community partners. We also had health authority partners, divisions of family practice, Royal Roads University. So we created the core research team with Solid and Umbrella to drive forward the research and make sure it was done in culturally safe ways. It responded to community needs, and had a broader research team in which we all participated in. So that's kind of how we structured it in terms of a community-based research approaches. Had core team meetings, had large team meetings, lots and lots and lots of meetings. But the project expectations were developed by the community researchers, and they had 3 of them: to increase awareness, increase dignity, and contribute to a meaningful way in the community. And under those, they have some very powerful statements about what they're looking for and the change that they want to see. So we had to grapple with a number of things. We had to grapple with this whole term of patient researcher, and we had long conversations. And I know in the HIV field, we talk about peer researchers. Our decision was that we should talk about community researchers, that was a more inclusive way to speak about our community partners, and by locating them in the community, as opposed to academic researchers, as opposed to, I don't think anyone objected to knowledge users as a term that I recall in terms of our policy and practice partners. We had to make building trust and relationships a priority. And if you go back, we've done some work around cultural safety in hospitals, same kind of finding. It's building those trust and relationships that were a priority. And bringing people to the table was often because people had relationships they trusted, and then creating new relationships. We have to make power visible and invisible. And I think bringing forward some of those really tough issues about how people are paid, how do we use these findings? So we have the incredible potential, when all of us are at the table, to use the findings and really act and follow forward. We don't have to convince the policymakers. They've been involved in the research all along the way, and how we do that together is really important. So to end, we have to recognize our own power and privilege to build those kinds of equitable research relationships. And I would propose that part of our building a health equity movement is how we work to disrupt power relations every day, how we work to disrupt it in our practice at the individual level. When a colleague uses language that sounds stigmatizing or insensitive, that's at the individual level, into our relationships and into the very system itself. And I think it's at those different layers that we need to constantly do that. But it really requires us to have that critical background and that critical understanding of what people are saying, the language they're using, what kind of values are embedded with this, as well as that vision for what kind of change do we want to see? What do we want to improve? And I think, you know, in the project I was describing, we were all unified about the fact that the problem was the need to address stigma related to substance use, and what could we do through a project, and the conversations and the shifting of language that we can do. And when I think about the HIV movement, and I think about what's happening in the overdose, we have very powerful opportunities that we've never had before to make these shift and changes. So I look forward to any questions, comments, thoughts, ideas about how we work together and move forward. Thank you.
Thank you, Bernie, for, as always, an excellent talk. As you know, I'm HIV positive. There's no ideas actually how many HIV positive people there are in this room, because that's not a question that CAHR asks of registrants, although it is a question that CAHR asks of the 80 scholarship slots that were available to this conference for people who are HIV positive or work in AIDS-serving organizations. I note when I pull up the registration page here, it says the HIV community member rate is no longer available. Please refer to the community registration page for scholarship information. There were 80 scholarships given. I know some of those scholarships were distributed geographically, and they actually went to people who were unable to find scholarships to come out here. I'm wondering what your thoughts are on a conference that is dealing primarily with an infection that many people, hundreds of people who actually live within a 5-minute walk of this facility have been dealing with for a long time, and they are not given the opportunity to attend this conference due to the withdrawal of the HIV positive community rate, and how you would feel if you were asked to speak at a similar conference, for example, the Canadian Association of People Who Use Drugs, or CAHR2018, and you learned that there was a limit on the number of scholarships or admissions for people who actually are using. To me, I find the registration fee for students, new researchers, at currently $325 is an economic discrimination, and I find the whole process stigmatizing. And when people experience stigma, I think it limits the potential for healthy outcomes. Your thoughts, please.
Thanks, Andrew. I think what you raise is the issues around recognizing power and privilege and who has the privilege to attend, and how do we support and ensure a more equitable kind of approach. I try to think about how do we address this in ways that come from a place of humility. And I think about driving up last night to the hotel and how uncomfortable I felt. I felt uncomfortable because I knew I could be here because I'm an academic. I knew I could be here because I had economic resources and supports. And, you know, over the years, I've done a lot of presentations with people who use drugs, to use that term. I could never imagine, and I doubt that I ever would do a presentation where I was invited to speak to them, because to me, that would not be in keeping with kind of how I understand the world. And it's interesting, on Thursday, I think this is kind of a classic example, I was asked to come with someone who was asked to speak as a person who uses substances, and they didn't have a second to go with them. And I was completely honored and privileged that they asked me to go as a second, as someone who is identified as an ally. And so I think it's that constant thinking about power and privilege and how do we get in the right relationships from a place of humility. Thank you for raising it, Andrew.
I just want to make a comment about the 80 community scholarships. The number 80 came from the fact that historically approximately that many community individuals applied to come and register to come to the conference. There were just over 100 applications for the community scholarships this year. There were only 5 that were not given community registration, and those 5 were generally academics who'd not applied appropriately. So every other person from everyone who was actually from the community, 103 people were given scholarships to come for free to the conference this year. There were 5 travel scholarships that I know our community representatives and their helpers spent a lot of time picking those people, and they received full scholarships to come to the conference, including airfare and hotel where required. And they were chosen to represent individuals from across the country. This represents approximately an $85,000 commitment by the CAHR board to support community members coming to this conference. And I think that's a great step forward towards community membership in this conference, and that we're doing our best to involve the community in this conference as they should be.
Yes, hi. Chad Dickey. I'm with AIDS Vancouver in Victoria. Just to comment about what you're talking about, the decolonization, plus also we're looking at how we do research. I think one of the things within community-based research and with health research is we really have to put away Occam's razor and start looking at other ways of looking at how we can be iterative, how we can be a little bit disruptive with how we approach community-based and patient-centered needs. I think that's a real important piece that you brought up. One other thing too, I just want to make a statement that AIDS Vancouver Island, we did open up an opioid agonist therapy clinic in the West Shore, which is a suburb of Victoria, and we did that with our own reserve funds. And the clinic, we expected it to have 100 patients after 1 year. We're already at 80 after 6 months. We provide full opioid substitution therapy, plus also HIV, plus also support for families that the grandparents are bringing in their adult children, they're bringing in their grandchildren. So there's lots of things that we're piecing together. The one thing too is our clinic is 1 block from the Premier of BC's constituency office. It's half a block from the City of Langford's City Hall, and we're right across from a school. So this can be done. I think it's something that is maybe somewhat unique to our atmosphere in Victoria, where you're from, and I think you have a lot to do with that, and I just wanted to make a shout out to you and all the great work that you've been doing, and also the great work that the community in Victoria has been doing towards this. So thank you.
Thanks, Chad. And a huge shout out to Chad and AIDS Vancouver Island. We're very lucky. Do you have time? I think are we done? No more questions? Oh no, I never know if that's good or bad. I'll find out later.
Well, I think the mic's off. Thank you, Bernie, for that comprehensive and I think inspiring talk. I'm sure Bernie will be around to be grabbed in the coffee area for questions, comments, more dialogue. David and I would just like to thank you so much for coming over today and for doing the talk. And I think, and we need a photo, do we? You need a photo? Okay, here we go. And now it is time for poster break.